Greetings and welcome to Healthcare Leadership Live. This is Mike Lyons. I'm your host, and we are here once again to share wisdom that will help healthcare clinical leaders to be more effective and to run more effective businesses. And our guest here today is going to help us with that. Her name is Elise Levine, and she is from iMed Management. Thanks for joining us, Elise.
Thanks for having me.
Elise is an expert in ophthalmology billing, and we have a number of topics here to cover. And that's a critical area for an ophthalmology clinic. I mean, if you don't do billing and if you don't do it right, you're going to find yourself, putting up a for sale sign in front of your practice, right?
Absolutely. Absolutely.
So yeah, I'm curious, Elise, how did you get into this work, and what has kept you involved with the billing world?
So it's funny that you asked that. I kind of fell into ophthalmology in my early 20s. I was working as an executive assistant at a company and I was kind of tired of it. And my sister, who was in college at the time, was working for an internist. And I said, I think I want to work in a medical office. It sounds exciting and fun. And she heard about this practice that had an opening, and I came in and started at the front desk, which is where a lot of ophthalmic leaders start out, which is great because when you've worked every aspect of the office, you really understand the inner workings of an office. I started front desk. This was before fax machines. This was before a lot of really cool tools that we have now to make life easier. And did front office, insurance, billed insurance on Thursdays when the office was closed on a 1200 baud modem, which probably most listeners don't even know what that is. Did visual fields, learned how to do contact lens training, sold optical, learned how to refract in tech a little bit. But really, my love and passion is the overall management of the office and especially the billing. Kind of just progressed through jobs. Had a brief stint, though, well, a little more than brief, working for Blue Shield of California in Medicare benefit development, which gave me a really keen insight into the insurance side of things.
Mm.
And then came back into ophthalmology. Have had a couple other little places outside of ophthalmology, but now I'm back in full time, probably for the rest of my working existence.
Well, what do you think? What is it about billing that you like so much?
Um, to me, it's like a detective kind of
Mm.
job. Putting a claim through that's clean is great. Getting paid in 21 days within a window is great. Making money for the practice is great, but it's those interesting claims, those unique diagnoses and procedures, just putting puzzle pieces together and feeling rewarded at the end when you know the claim was paid, the claim was adjusted, the denial was overturned, that you got the appeal done. And then, kind of on a broader sense, having been so involved with the academy over the years and having this network of other ophthalmic practice professionals, having us affect change, where when there's an error out there with Cigna or Aetna or whoever, and somebody says, hey, are you experiencing this? And we find out that hundreds of us are experiencing this, and working with the academy to actually get things fixed. I think that's a really rewarding piece of it. And at the end of the day, you're helping save people's eyesight.
Yeah, that's amazing. If you can combine interesting work with purpose, then that's a recipe for a life's work right there. And it
Right.
sounds like that's what it's been for you. And I
Yeah.
certainly get that from the people I interact with, in ophthalmology as well. And so it's awesome that you found that. You talked about being on the inside with Blue Cross. I'm kind of curious, like what I'm sure you gained some real interesting perspective from that. That you can apply today, right? And so I'm kind of curious, maybe what's something that you took away from that experience that you think makes you more effective in billing?
So I think part of it is, when you are a small practice and you're having a problem, I know that there are a lot of really engaging folks that want to do right by the patients, do right by the doctor. One voice is not going to make a difference. Having been on the inside, even when it was onshore, one doctor's office complaining about something, provider relations would laugh. And when there are a million ophthalmologists in your community that can do the same thing as you, the squeaky wheel doesn't necessarily get the oil. The squeaky wheel gets the letter saying, we've decided to take you off the panel. And so, really being thoughtful about what you need, what's going wrong, and aligning yourself with some of the national advocacy groups that we have, like the American Academy of Ophthalmology, like ASCRS, that have advocacy teams that can go out and get in front of the medical directors, get in front of the policymakers. That's going to help you with change. And also, not sitting back and just complaining about the situation, getting involved in these organizations too, because that gets you a direct line to folks when you do have a question or a concern.
Mm-hmm. And I know that you have been heavily involved in these national organizations advocating for doctors and practices. So thank you for that. I'm curious, as a person who I pay a lot of attention to the healthcare world and what doctors are saying, have you seen a change in the tone or the level of, I don't know, frustration maybe that practices and physicians are having with payers and, CMS and all that, and the red tape and all that? Has there been any change? And if so, what have you noticed?
So I think across the spectrum of ophthalmology, it kind of depends on how you come into the field. So if you are able to afford to start a practice on your own and you have ample resources to do that, then it's a very fulfilling opportunity to run your own business. A lot of doctors don't have that opportunity. And to start off by yourself and have to finagle your way through all of the red tape, you notice a lot of young ophthalmologists joining groups or joining healthcare systems that can handle all of the red tape for them. Some doctors love the aspect of business. They've gone to school for a combined MBA, MD, and that's their jam. There are other doctors who are like, I would like to just do microsurgery of the eye and get paid a fair share for that, but I don't want to deal with the minutia. So I think you've seen a real separation of those who want to work in a system and those who want to be business owners. And the work that I do now really is helping the smaller business owner that realizes they don't have all the resources at hand to maintain a functioning office.
Yeah. Yeah. And so I guess that kind of was my thought as you were talking there is, do you help to fill that niche of that provider who kind of wants to have their own business, but they're feel a little bit deterred by that? And, is the help there if they want to try to be independent?
Yeah, I mean, I think that there are a lot of technological advances that are helping with that. I think COVID really brought it to the forefront of being able to look at your office and say, how many actual humans do I have to have present to do the job? I know I need a tech. I know I need an optician. I know I need at least somebody in the front to help kind of manage checking people in, checking people out. But with technology, you can get a lot of your copays collected before the patient comes in. You can outsource, offshore, onshore your phones, that all your appointments are going through somebody who doesn't have to physically be in your office. Billing can be removed from inside the office and be done anywhere. And that's one of the biggest things that when I talk to people is when you have 3 people sitting in an office doing your billing, could you convert that space to a testing room, to another procedure lane that, it's a revenue producing square footage versus having 3 people sitting in a room doing billing that could just as easily do that from home or somewhere else. So there's just been a lot of ways to kind of really streamline what you do. Now, sometimes there is a bit more cost, it feels like, to outsource things. However, most doctors don't really look at pro formas and don't look at what an overhead cost is, and don't immediately calculate in their head the cost of benefits, 401k, vacation, sick time. And in a very small office, if the biller is out, then who covers the billing? If the tech is out, they pull the biller to work as the tech. That means no appeals are getting done. So you're always robbing Peter to pay Paul, and there are solutions. So it's a very different world than what it was 10 years ago, 20 years ago, pre-COVID.
This show is sponsored by Seasoned Advice HR Services, where I help clinical healthcare businesses to make more money and save more money by hiring better, retaining better, and reducing your HR risk. If you would like an HR assessment or ongoing HR support, please reach out to me at seasoned-advice.com. As a fellow support to those independent doctors, I can definitely identify with that. And I think that there is a trend. I think there is still that desire for physicians to be independent, and maybe some of them. I'm curious, have you seen a trend in providers wanting to escape, let's see, for lack of a better term, their employment arrangements and go independent, or maybe join a independently owned practice?
Yeah, I mean, I think that no disrespect to the venture capital, private equity model, for some it works, but for a lot of doctors, they see this as a model that's not sustainable for them, especially if they're entering into it in the latter third of their career, where now they are being dictated as to how many patients they need to see. It becomes a very numbers driven game. Whereas at a solo practitioner, if you want to see 25 patients in a session or you want to see 50 patients in a session, that's your decision, and that's your office to run. Whereas you lose some of that ability to drive your own car. Now, again, for some docs, it's kind of like there's a lid for every skillet. Some docs like to just come in and be told, here's your schedule for the day. These are all the people you're going to see. This is surgeries you're going to do. And that's great. But for other docs, they want some more autonomy in their work. And so we have seen practices that have come out of group settings or private equity settings and reestablished themselves as solo.
Yeah. I want to say now, for anyone listening live here, Elise has a ton of ophthalmology billing knowledge. If you have a question related to billing, or probably just ophthalmology administration in general, she's a great person to talk to. So you can submit a question or a comment, and we would love to hear from you here live on the show, and we will address that right here. So with that, Elise, what is, there are a lot of, I'm sure there are different folks listening to this, from large to small to maybe a doctor thinking about starting a practice. What is maybe a tip that you think would be useful for the average practice out there to help them improve the way that they collect on their claims?
So we teach a class at most meetings called How Everybody Touches the Billing Process. And I think that a lot of doctors may not recognize how literally everybody in the office really can impact billing. And it starts with answering the phones. So when you answer the phones, are you ensuring that the patient that's making an appointment can be seen in your office, that they do have the right auth, you are in network, so that the patient doesn't show up, and when you look at them, you turn them away, which you've now left an empty hole in your schedule.
Mm.
When you check in the patient, I think this has to do with job expectations in a lot of cases, and we do a lot of training on this. Your front office is there to collect money. And if they're not there to collect money, then they should be in a different position. And there are a lot of really good ways to teach people how to collect money. You don't just say you have a $10 copay today and the patient says, I forgot my wallet. Well, how are they paying for the parking? You say, today's visit will be $42. How would you like to take care of that? We take check, cash, or credit card. And you create the conversation that there's an expectation there. And patients start to understand that when you come to the front desk, there is an expectation. I don't know anybody who has a blocked toilet or a disposal that needs a plumber to come out, and the plumber comes out and does the job and say it's $250, and you say, I'll get to you next week. It's a service that needs to be paid for, especially when it comes to collecting at the front desk, because these little copays of $10 and $20, they lose their value the minute the patient walks out the door and doesn't pay it, because to send a statement and the work behind a statement takes away, you're now collecting zero. So there, when your techs take patients back, how are they asking the patient about their chief complaint? What brought you here today, Mrs. Jones? I got a postcard from you. Well, getting a postcard from you does not constitute as a medical diagnosis that's going to get a claim paid. If you look at the chart and you say, oh, last year you said that you had changed diabetes medicine and your sugars weren't well controlled. How are your sugars now? Getting that in the chart helps get the claim paid. The doctor doing only what they are supposed to do within reason and not adding on extraneous tests that won't get paid at the same time of service helps to get paid. And then again, on checkout, if you have an optical, is your optical collecting at least 50% of the job? Is your checkout person making sure that they collect? Every single person can help impact that collection. How are your statements going out? Do you give people an opportunity text to pay? Do you have a portal that they can pay online? All of these things, the faster the money gets in, the easier it is to pay the payroll and all the other overhead.
Yeah, you know what? Make it easy for the other person is something I think I'm hearing from you, and I think that's great advice. Like, it's already something that is difficult for some people, or they don't want to think about it. Like, let's make it super easy. I'm assuming, like, how do you want to take care of that today? That is a great tip there. We do have a question here from Eric Hutter. From your perspective, what are the biggest missed revenue opportunities you typically see in ophthalmology practices? What a wonderful question. What do you have for us, Elise?
I think it's assuming what a patient can pay. Doctors are often sold on ancillary cash-based services, and there is a lot of assuming that can go on from a lot of different people in the office. You always read those stories about in the Reader's Digest of the, high school janitor that, dressed like a pauper, but when he died, he had like $4 million in the bank. Never assume based on what the patient looks like or what your perception of what you think they could or couldn't afford, as an opportunity to have a conversation with them, whether it be a premium lens, whether it be upgraded eyeglasses, whether it be any of the dry eye treatments that are out there. These are things that we have to offer. It's much easier for the patient to say no than to not make the ask.
Make the ask. That's a great tip right there. What are some typical mistakes that you've seen? Y'all have a lot of clients across the country, and I'm sure that when you onboard a new client or even some of your existing clients, you see mistakes being made and that you can kind of pick up some easy low-hanging fruit. What are some of those typical mistakes that you see practices making in their revenue cycle process?
It's interesting because practices come to us for two reasons. One is they are establishing a new practice, whether they're leaving a group or they're just starting out, or they're a hot mess and they need help. The biller who's been there for 30 years suddenly had a reason that they had to move across country and couldn't do the billing anymore. And when we get in, we look around and we're like, wait a minute. When I meet with prospective clients, I'm looking at a few things. I'm looking at what their 120-day aging is. I'm also looking at like what their most recent aging looks like from a patient pay standpoint. I can look at it aging really quick and tell you the front desk is not collecting. If I see a ton of $20, $30 balances for patients in the first 30 days, I know that your front desk is not collecting. So again, we will train any area of the office where we see deficiencies, but I think some of the low hanging fruit are having people that can strictly work the AR and making sure that your old AR is either getting written off if it's out of timely filing, not collectible, wrong insurance, the office messed up. Getting statements out to those people who have a patient pay responsibility, and or figuring out what your collection policy is going to be, whether you're going to adjust it off for the next visit or send it to collections. And then making sure that the front desk is collecting as much as they can at the front end of the visit, because that alleviates the 120-day aging in 120 days in most cases.
Okay. What are some key metrics that a clinic should establish for their RCM program?
So it's interesting. I mean, right now it's a little wonky. I think most of all, we're looking at 120-day aging is less than 5%. You also have to look at your payer mix. So, if you're a practice that's seeing straight Medicare, PPOs, things that should be paid cleanly within 21 days, you can see pretty quickly what's going on. When you add retina drug to the mix and you add HMOs to the mix, know who your payers are, know what your payer timely filing limits are, and figure out where the bottlenecks are. If, suddenly a payer requests records for every claim and you know that up front, send it up front. Don't waste time waiting for it to get rejected to then send it. But if you are within, the industry benchmarks of, I always look at 120 day as the benchmark, because 60 and 90 can be the wonky requesting records appeal kind of things. Also, the other thing is that whoever is doing the billing, when you send your first batch out to the clearinghouse, you want 99% of those claims to go the first time. The 1% that don't go should be worked immediately. The demographics don't match. The address doesn't match. Something doesn't add up. It's the wrong insurance policy. Fix that immediately and get it back out. Then the other problem is that when somebody's posting the payments, the denials that are on that EOB, work those right away. Don't put those in a pile for later, because that pile for later becomes the pile for never, because you never have time to go back to that pile. So always work things as you first touch them to at least get a process started and not run out of a timely filing window.
You talked a little bit about billing staff, internal billing staff, and I'm sure that this is a question you get a lot, and I can foresee your potential answer here. But is there any kind of benchmark for how many staff you should have doing billing?
So, most people from the old days when we used to ride dinosaurs to the office, kind of live, breathe, and died by John Pinto's benchmarks. Everybody knows the Pinto benchmarks for staffing and revenue and all those things. The problem is that book came out before HMOs were so prevalent, as well as so many things that require authorizations, prior auths, denials, etc. So you really have to look at your payer mix. You could have, again, a clinic that is no HMOs, everything is PPO, easy breezy, and you could have somebody that could be really able to just grind through claims. My feeling is that once your 120-day aging gets over 5%, you got to look at what's going on and figure out, do you have enough people? And not only do you have enough people, but it's, there are offices, retina offices, that have billers, payment posters, prior auth people, and the people that work denials. And one of my tips out there for anybody in leadership is cross-train those people, because you're doing them a disservice by pigeonholing them into one role. We interview a lot of folks who have only been a payment poster for an RCM. We want somebody who knows how to do the whole thing, because how do you mentally understand the whole process if you haven't done the whole process? So I think it's really important that you cross-train people, because you need coverage, but you also cross-train people because it helps them understand their impact on the revenue cycle.
Yeah, that's huge. Helping all members of your team understand the different roles and how what they do impacts something else is super important. I've seen that, and I support that kind of thinking when it comes to your technicians and your front desk. Like, I want them to understand the billing team. I want the techs to understand the billing team, because, as you said, all of those people affect the revenue cycle. They're in the revenue cycle, right?
Well, and even I want the front office to understand the techs. I want everybody to understand the lack of preparation on your part now caused this. I want you to see what the schedule looks like, because you didn't ask the right question, and now the patient is here wanting a contact lens fitting, and that was never on anywhere. And now that has impacted the schedule by 45 minutes, and look what it's done to the waiting room. And now you've got people yelling at you, and you're blaming the tech, but it wasn't the tech. It was whoever made the appointment. So I think it's really key for everybody to see, like, you're not doing this made me sit on hold with Aetna for an hour and a half, because we should have had the auth for the cataract surgery ahead of time. And I think people understand when they're impacting other people's workload.
Yeah, I mean, what we're talking about here really has to do with onboarding and training your team.
Yes.
And you could have the best person at the front desk, you could have the best person working denials, but if you don't onboard, train them well, communicate with them, just like what you're talking about, then you're not going to be operating at a high level.
And having SOPs, because onboarding and training, when you have somebody sit next to the other receptionist to learn how to be a receptionist, they're only as good as how they were trained. And unless they have a written document with expectations, this is what you do today. You open the bank, you count the bank must match, you turn the bank in, you turn off the phones, you water the plants, because somebody's going to say, well, nobody ever told me to water the plants. And it's like, well, that's number 7 on the SOP.
Yeah, have a list, have a process, and maybe review that process every so often, and and review it with the team. If you make a change and don't tell anyone, that will not have a good result, right?
And from an HR perspective, which I know is your jam, SOPs are the key way for you to be able to document performance or not.
Yeah, I mean, have we trained people? Have we given them clear direction on their job expectations? And so many times an office will say, we're ready to fire Sally, but they haven't really done a good job of training and teaching, onboarding and integrating. And at the end of the day, it's a bad reflection on your practice if you end up letting Sally go and you haven't done your job.
Exactly.
Yeah. You talked a little bit about the front desk, and they're part of that cycle. You talked about collecting, other things besides collecting for the front desk or the check-in desk or check-out desk that you think would be important to to emphasize for them to maximize your revenue?
So I think that the front desk over the years has become the catch-all for everything.
Mm.
And I think that these folks are overwhelmed in a lot of cases with too much to do when when patients are not arrived because you missed them, copays are not collected because you were on the phone trying to do something else. I am a big believer in keeping the phones out of the front desk area if you
Mm.
can. And that's a great reason to outsource for appointment making because you can teach anybody what to triage an ophthalmology call and
Mm.
let them triage and buzz the office if they're not sure. Patient says their eye is red and hot and is in pain. Is tomorrow okay or today? But don't put that burden on the front desk who's also trying to collect a $57 old balance from Mrs. Johnson who needs an explanation of why that balance is there. So really it's like if you want them to collect money and you want them to make sure patients are being arrived and that they are getting to the back, let them focus on that.
Mm.
I think, it's, oh, can you do these authorizations while you're up here? Can you do the, nothing's going to get done great. Things may get done, but nothing will be done great.
Interesting. We're kind of getting into HR topics a little bit, and I always think about, when I've had to hire billing staff or front desk, I think about certain characteristics, right? And they're all always kind of different. When you think about hiring someone for the billing team, what are some of your top characteristics that you look for?
We definitely want people who understand about taking the next step. They're not satisfied with whatever the answer is.
Mm.
If it's a denial and they say, oh, it's been denied, well, why has it been denied? What would it take to do a first level appeal? So really, these are people that we need gregarious people who will look into and are willing to investigate. They're detectives, really. A detective is the best biller because they will look at all the options. If the insurance is not correct, what are you going to do? Well, you're going to send a statement that says, we don't have the correct information for you. This bill is due and payable unless we receive a copy of your insurance card. You're not going to just leave it for next month's aging to review again. So we're really looking at people who have common sense, know how to take the next step, understand the RCM cycle, but also understand ophthalmology, because I think that's one of the hardest specialties because you've got vision, you've got medical, you've got optical, you've got different kinds of insurance plans. You can't be a GI expert or an OBGYN expert and then come into ophthalmology and act like you know what's going on. And there's just so many nuances with our industry that when I'm hiring, I ask specifically, do you have ophthalmology experience? And everybody says yes. And then I look at the resume and the answer is no. And that's a pass for us.
Mm. So for a business like yours, having some kind of ophthalmology background is really key.
And you could have, and a lot of our staff, well, all of our staff are ophthalmology experienced. A lot of them have worked in different positions in the practice before they ended up in billing. So they also have that awareness of what it means to be a check-in person, what it means to be a tech, what it means to be a scribe, how to help a scribe do a better job scribing to get paid. And when we see these misses in the practices, we will train the techs. We'll do a lunch and learn via Zoom and, give them tools for better scribing, better collecting, better whatever it is.
Yeah, I think that you just mentioned something that's really important there, which is the people that are scribing, coding, that is super key. They need to really understand the issues that are going on, and maybe there's something that continues to pop up and we haven't addressed it. That sounds like a recipe for, just continued failure.
Right. And sometimes, I know a lot of people. I personally, I love to mentor folks. I love, and I do mentor people. Um, but unfortunately, our business is not a training ground for folks. We need people who already have the experience.
Yeah.
I've worked in opportunities. I did some workforce development for a couple of years where we were training folks who came outside of the medical field to train them for non-clinical medical roles. And, that's a different game. But when at the high rate of claims that we're doing, the fast pace that we're in, unfortunately, we need people who have, a certain level of experience. And offices have to weigh that out. Sometimes you say, oh, I can bring her in and train her. She's really smart. You could be really smart at algebra, but you might not be really smart at coding a complex cataract and what the ICD-10 codes that need to go with it are.
Mm.
So,
So hire carefully, hire carefully. Yeah, I think it depends. It definitely depends on your practice. If you can hire someone based on just character alone, or if you need someone who has that billing and or ophthalmology experience. That's really going to depend on your situation. I think if you have a bigger practice and you have a robust billing program, yeah, you can train some folks.
absolutely.
Start them at the front desk, start them at verifications, and grow them over time, kind of like what you were saying.
And if you're small and you want to take that on, spend the money for the education.
Mm.
Send people to the academy, send people to the coding camps, or pay for all the coding information courses that you can online.
Mm.
The worst thing I ever saw was talking to a practice that had ICD-9 books that were over 10 years old. And there are a lot of practices that are not keeping up to date with what is the newest, latest information, and that denies claims. They say, don't bill this anyway anymore like this, and you keep billing like this, you're adding another 30 days onto the waiting for the money.
Mm.
So stay on top of all of that education.
I'm wondering if we talked a little bit about advocacy. Are there any pending or major expected reimbursement changes that are on the forefront right now or in the near future that are expected, that you can share with the show audience?
I mean, there's always, end of year, waiting for the new budget kind of thing changes. I know that both the Academy and Ascaris are fighting the good fight to reduce reductions in payments. Really, I think the best thing anybody can do is become a member of either one or both of those groups. Stay on top. There are emails you get from them daily. There's a weekly roundup to stay on top of those things, and for the doctors and staff that are comfortable doing it, to get involved. There are always opportunities for the MDs to get involved, to call their local congressman or senator, or work through the agencies to go to these advocacy meetings. I used to go to Washington, D.C. every year and lobby, and talk about things from a practice administrator's perspective. You really have to just, and again, every specialty has its own nuanced things going on. Like when Good Days went away for however long it's been gone, that everybody in retina was up in arms, but it doesn't affect the comprehensive practice necessarily. So it's just really important to stay on top of all of those things so that you are aware immediately of changes.
Awesome. Well, Elise, I'm sure we could go on for a long time talking about this stuff, and I truly enjoyed getting to know you over the last year or so. How can people get in touch with you if they have questions about billing or the work that iMed does?
Yeah, so the easiest way is to reach out to me, Elise at imedmanagementsolutions.com, or look for me on LinkedIn. I always accept LinkedIn connections. And iMed Management, we do kind of a robust social media sharing of latest tips, tricks, news. You can follow us there as well. So I would love to hear from anybody.
Okay, and I will put your contact info into the show notes.
Great.
Yeah, and with that, thanks for being on the show, Elise.
Thank you. Great being here.
And thank you to everybody that has been listening, either live or on the recorded show. I truly enjoy the opportunity to have experts on the show to share information, help you be a better manager in your practice, and help you be more successful. Because at the end of the day, we're all here to take care of patients and to make sure that the physician can do their work as best as possible to help the patient. And it ultimately benefits everyone involved when we continue to learn, we continue to grow. And so I'm going to continue to have great guests like Elise on the show. So thanks for listening. Please subscribe if you've enjoyed this content, and share with someone else who's in ophthalmology, so they can learn from Elise's knowledge as well. So with that, I will bid you adieu. Go out there and lead with confidence.